and why it get importance if we compare with the right bundle branch block. LBB getting more importance, but why? And before that, going to this inside of LBB, at first we have to know and keep in mind the how conducting system and electrical activity traverse in the heart. From SA node is all of you know that it's a physiological pacemaker and intrinsic rate 60 to 100 per minute and originated from SA node, traversed the AV node through the internodal pathway, and from AV node to his bundle to the left bundle, and also its vesicle, left anterofesicle, left posterior vesicle, and also right bundle, Purkinje fiber, endocardium to epicardium. In this way, normal physiologically electrical activity traverse and causing the depolarization and repolarization as well. And this is the mechanical activity, systole, diastole, everything. So anyway, when the left bundle branch block occurs, then the from electrical activity from AB node, his bundle then traverse through the septum in the right ventricle at first, and right ventricular depolarization at first, and the initial part of the M pattern ECG, white QRS complex M pattern is in the initial part is formed by the right ventricular depolarization, and gradually, slowly, and this electricity traverse from right to left ventricle and causing the later part of the complex. This is the part of the M pattern or rabbit air pattern QRS complex, last portion or last part of the QRS, right? Left ventricular depolarization, but not like the physiological uniform and combinedly depolarization, simultaneously depolarization of the both the ventricle and the causing the normal morphology monophasic QRS complex. And how can you define just showing ECG? LBB is the usually white QRS complex, usually 120 millisecond or more than 120, equal or more than 120, and also laterally that we consider 1 AVL and B5 BC, there may not be present QA. This is due to septal depolarization, and there is a cut down of the left bundle branch block. There is a lack of septal depolarization or no presence of QA in the 1 AVL and B5 B6. So that one of the most important criteria that there is may not be present and usually not be present QF in the 1 AVL and B5 B6, and DPS in B1 B2, and seems to be the old MI septal. There is a ventricular right ventricular depolarization in the first, and there is a muscle mass is less, so that there is a teeny R wave and the long S wave. And the later part B5 B6 and 1 AVL lateral portion, there is a left ventricular contribution is more. There is a taller, and it's also M pattern or rabbit type pattern. And now we keep on over the etiology of left bundle branch block or underlying cause. One of the most important cause, aortic stenosis, aortic regurgitation, systemic hypertension, especially poorly controlled or uncontrolled long-standing systemic hypertension, and ST-MI equivalent, ST-elevated MI equivalent when the Garbosa criteria fulfill, and previously not required Garbosa criteria for labeled as the new onset LBB or presumptive new onset LBB treated like as ST-elevated MI. That means it is suitable for primary PCI if patient come timely fashion or after getting the pharmaco-invasive, that means the pharmacolytics, and then we can cath lab activation and angiogram, and further management depends on this the condition of the vessel, coronary artery. So that the Garbosa criteria fulfillment when then severe chest pain with new onset LBB and Garbosa criteria fulfillment, then treatment according like the ST-elevated MI. Okay, and the heart failure, one of the most common cause development of LBB, left bundle branch block. Around 30% cases heart failure the causing the left bundle branch block, and it is the vicious cycle. Left bundle branch block make causes gradually LB dilatation and left ventricular failure, and sometimes the ventricular failure causing the left bundle branch block, and the left bundle branch block causing the heart failure, and ultimately malignant in the ventricular tachycardia, ventricular fibrillation, and even the poor, very poor LV systolic function causing the sudden cardiac death. So you have to keep in mind the treatment should be accordingly its etiology. Like the heart failure, we have to treat heart failure by updated guideline using the Fantastic Four. And the, if hypertension not controlled, there is a well control of the blood pressure to keep in mind, and target blood pressure level maintained according to the guideline. And also the other anti-ischemic therapy if patients the ischemic heart disease, that means the after acute coronary syndrome, ST elevated MI, the LBB pattern ECG, Garbosa criteria, then we have to maintain the anti-ischemic therapy. Or in anti-ischemic, that means the antiplatelet, anticoagulant, and others, anti-remodeling drug, ACE inhibitor, RNA, something like that. And aortic, one thing is that the LBB almost always pathological, but sometimes there may not be seen any identifiable cause. The few percentage of the patient, especially elderly, there may not be identifiable cause. So it's maybe idiopathic or unknown cause that cannot be explored. In that case, and patient incidental diagnosis, or patient required any operation or any surgery. So patient is asymptomatic, elderly. In spite of patient asymptomatic, the LBB should be undergone treatment, should be treated accordingly. As because one of the largest trial, Rotterdam trial, shows that those group asymptomatic of LBB pattern ECG under treatment, they reduce the mortality and reduce the form of ventricular arrhythmia, and also reduce the recurrent hospitalization, the heart failure. So that when LBBB, even in asymptomatic and the preserved ejection fraction, should be undergo treatment. And should be considered for treatment, under treatment, and according to guideline LBB. And the one most important thing is the management of the LBB. At first, you have to consider the underlying cause. If hypertension, well controlled hypertension, and if aortic stenosis, so aortic valve surgery or TAVR, SAVR, something like that. In case of sometimes the iatrogenic cause of a left bundle branch block, like the during TAVR or SAVR or septal myectomy in ASOCM patient, causing the, and sometimes EP study, ablation study, causing the iatrogenic left bundle branch block. So apart from drug treatment, there is some treatment required, like CRT, cardiac resynchronization therapy, as because there is both the ventricle, that there is a dysynchrony movement, as they reduce the ejection fraction, and the patient is symptomatic. So CRT or CRTT is very much important, one of the modalities of the treatment. And another treatment, sometimes they required, if there is a aneurysm, ventricular aneurysm or excessive dilatation, so there is a reduction surgery, aneurysmectomy sometimes is required. So ultimately, take away message, the LBB almost always pathological, and treatment depends on its cause and the patient's symptoms, and its consequence to prevent the complication of the LBB paternitis or LBB. It's called LBB diagnosis due to cause like the aortic stenosis, or very much important emphasis the when the LBB in the setting of acute coronary syndrome. It's very much important. It's the patient needed the thrombolytics and the coronary angiogram. And so take home message again, I would say the At first, identify its etiology, and patient either symptomatic or asymptomatic, or patient's LV function and ejection fraction, that means, and the patient's causal factor. And when even in spite of patient asymptomatic, patient should undergo treatment and to reduce the development of heart failure, malignant arrhythmia, even sudden cardiac death, or recurrent hospitalization due to the heart failure. So all about this left bundle branch block pattern ECG, its etiology, its causal factor, its symptom. So symptom usually depends on the etiology. If there aortic stenosis, there may be exertional chest pain, shortness of breath, and if even heart failure, there is a shortness of breath and congestion, both peripheral congestion or central congestion, lung congestion. Chest X-ray shows there is a plethoric congested lung field, and echo also is one of the most important modalities for the diagnosis of the LV systolic function, ejection fraction, and the marker NT-proBNP, one of the most important marker for the heart failure. And sometimes the troponin I, when the Garbosa criteria fulfill the new onset LBB with Galbusa criteria, then in that case the troponin I is required not only diagnose, also its prognostic pattern. If raised troponin I is so much more higher, it's the especially high sensitive troponin I, that's a prognosis is bad. So with caution about this management of this LBB ECG or LBB pattern of ECG with having some disease condition or situation. So this is all about the left bundle branch block, underlying cause, symptom, and it's what are the investigation and the prevent the complication, and follow-up. Follow-up is very much important as because the patient discontinue when the patient feeling better, then discontinue the drugs. So you have to keep in mind that the drug compliance is very much important, and the underlying cause should be treated accordingly. Without treatment of underlying cause, it is very much difficult to control the patient has got the left bundle branch block. So thank you very much. Thank you everybody.